Okay, welcome everybody to our second MS Variance meeting called Raising the Bar. It's quite incredible to see a full room after our first meeting in November last year. And hopefully this is going to be a little bit different. This meeting is going to generate definite work streams, definite action points, and I would imagine if we do this meeting again next year, we're going to have some progress. So before we go on, there's some, let me just get the next slide. This is last year. We're going to have a team, we'll have to have another team photograph. David Rogg was adamant that we collect a series of these pictures, so we'll have to do one maybe tomorrow at lunchtime or something like that. Is that reasonable? And so this is what started. My Slido slide has disappeared. I thought I had it first. So this is what started it off last year. So we were at the ABN in Birmingham last year, and we saw this variation in the prescribing of disease-modifying therapies across NHS England. And we know that this is a problem because Malcolm Quayle, the senior pharmacist, has nightmares over the wide variation in prescribing, and it's his job to get us to stop this variation. Now, the question is this warranted or unwarranted? And we suspect some of this is unwarranted variation. And the question is, why should somebody go to Centre A and get a different set of options and somebody goes to Centre B? And that's kind of where we're at this. So Malcolm Quayle actually put three things in place to try and get rid of this variation. The first is he thinks the blue tech system will do it, and we're going to hear a lot about blue tech data in the next few days. He thought by having an algorithm it's going to get help. In other words, there's a strict path you go down in terms of prescribing these things. And the final thing was he thought if you put an MDT in place, a multidisciplinary team meeting, we'll also get it. And those three things may help, but I'm not sure it's going to sort out the problem, and this is why we're having these meetings. And we actually had a debate, David Paling and I had a debate about whether or not those three changes will get rid of this variation. And out of that debate, we were having drinks afterwards, and we decided, look, actually, we need to do something formally, and that's what created these series of meetings. So if you look at the definition of variance, the fact of quality of being different, divergent, inconsistent, and there's a whole lot of synonyms you can see over there. It is problematic though, because why should individuals with MS be exposed to unwarranted variation depending where they go? And I've always argued that variance, when it comes to the provision of healthcare services, is a euphemism for inequality, representing the haves and haves not. But I actually learned at the last meeting it's not necessarily so, because on the other side of the coin, variability creates the engine for change. It's a catalyst for us doing different things. But the point about being a catalyst is you have to know about the quality of the service that you are providing and what you expect to receive. So we have to put information on the table. And I think that's what's going to come out of this meeting, is we're going to hopefully get a national audit, or at least a pilot national audit off the ground. And I'm hoping all the centres represented here, and you saw that slide that was going up before we started. There's about 71 MS centres represented at this meeting, and hopefully a significant number of you will participate in the pilot audit, and we'll start generating the necessary data to drive change. I actually wrote a narrative. If you want to read it, it's basically, I'm beginning to realize by telling stories you can get messages across easier. And if you read this, it's about two sisters. One gets different care compared to the other one, and the different outcomes. And if you read the story, you'll almost certainly recognize it in a patient of yours or one of your patients. It's just about being unlucky or lucky, and that shouldn't be really. It shouldn't be what the NHS is about. It shouldn't. Your outcome shouldn't depend on a series of lucky breaks versus a series of unlucky situations. It should not be like that. Another thing that's happening in the UK, and is across the world actually, is the incidence of MS is going up. And we're actually seeing this because a proxy for this is the changing sex ratio, and everybody who collects data is seeing an increased number of women getting this disease compared to men. And we just, as part of our MS Academy, had an incidence and prevalence done in Western Scotland and the Western Isles. And over the last 6 years, the incidence of MS has gone up over 30%. And I reckon the Western Isles and the Scottish Highlands are just an example of what's happening across this country. So we're getting it's a big issue. And then the NHS is in flux. I just put some of the things that are happening in the NHS, and we as an MS community have to respond to the changes, be it what comes from right care, sustainability and transformation plans, the algorithm, blue tech, and we're now getting GIRFT. I'm sure you all got your own GIRFT data. Is how do we respond to this and address the unmet need? And this is just an example from our centre. Joella gave me these figures about 6 weeks ago. It goes up to the end of January. And this is what's happened to MS disease-modifying therapies. These are patients in our centre on DMTs. Over the last 7 years, it's gone up about a factor of 4. And I know Jeremy Hobart's shown me figures from Plymouth, and it's almost identical in Plymouth. And I bet you it's almost identical in every other centre that's actively involved in MS. And Joella will tell you that over that time, we haven't really had any substantial increase in staffing. We're just doing this on the existing staffing level. So our efficiency's gone up, but it's gone up in this department, but it's gone down in other departments. And you can see the complexity is also changing. We're getting a completely different profile of disease-modifying therapies that have been prescribed. And as we move to more efficacious therapies, the pharmacovigilance burden goes up, and the demands on us in terms of pharmacovigilance goes up. So there's a change happening in the way we deliver our MS services. Another thing that's just happened is that we've got our first drug licensed for primary progressive disease. And that's good news, because for the first time, people with primary progressive disease have a treatment option. And maybe in the next 6 to 12 months, we're going to get a secondary progressive therapy licensed. And up until now, we haven't had a service aligned for progressive disease. So this is going to have an enormous impact on our services addressing the demand for progressive disease. All these people with progressive MS are going to come out of the woodwork, as I say. They're going to want to be assessed to see if they're eligible for these treatments, and it's probably going to put up our workload about 30 to 40%. So we have to work differently. So I talk about a perfect storm coming. So the perfect storm is the epidemiology of MS, increasing incidence and prevalence of the disease. The quality standards, so there are some quality standards from NICE. Another thing we don't agree with is we don't think NICE quality standards address the issue. They're fine, but we need many more quality standards than that. There's also some emerging international quality standards, and Jeremy and I have been involved in generating these with the Delphi process across the world. And I think we should sign up to those international quality standards. They are quite ambitious, but there's no reason why we shouldn't be as ambitious as anybody else in the world in terms of managing MS. And then there's stuff happening in NHS and NHS England with blue tech. We've actually had a reduction in number of prescribing centres. That's created large problems. So if you go into one of the spokes, getting into the hub for your treatment, a treatment, then I got a message here to explain Slido. I don't know what happened to the slide. So Slido is this thing so you can ask questions. So you all got smartphones. You're all registered on the wireless network. So if you just go on there and you put, is it slido.com or SLIDO? .com, okay.
If you need to get onto the Wi-Fi, it's the BCEC or the Holiday Inn, and the password is just free Wi-Fi, all lowercase, so that'll take you onto the Wi-Fi. And then if you go onto the slido.com, it'll ask for a login number, and it's just Y0H2. And then that'll give you, literally, it'll open up, and you can ask questions throughout the whole of the meeting, and you'll be able to answer polls as well. So it'll be very interactive.
I'm just wondering if you got my first slide set, that's the thing. But? No, I just think you got my old slide set, that's all. That's no problem. So the reason why we want you to have Slido is because one of the things that came out of the last meeting is we didn't have enough time for questions and discussion. And so it's going to be very important that we built into this program as much time for questions and discussion. And so one way of getting your questions asked, because another thing last time, certain participants were more verbal than other participants, and so the way to deal with that is by having a platform for you to ask questions. And we're also going to be doing polls. So I'll do this at the very end. Is will the NHS be better after Brexit? No, maybe yes. And you can see 95% of people already come in at no. So if you go into the Slido, you'll see there's two things. There's one for questions and one for poll, and you can ask questions as you go along. I already mentioned a lot of these, and then the NHS is very keen on us driving innovation, whatever that means. Sometimes less is more when it comes to innovation. There are changes happening with NHS in terms of long-term conditions and new service models. We're all part of SIPs, cost improvement programs, under the austerity umbrella. I mean, it goes without saying, every single year in our centre we get given a new SIP target, and it usually means cutting staff, cutting resources. It doesn't mean expanding staff numbers, expanding resources. Okay, DMTs, as I've already said to you, there's increase in complexity in terms of prescribing and managing the complications, pharmacovigilance requirements. So Ruth Dobson's here, she's running a program, and Matt Craner, a thing called Optimize, which is a national study for us to help monitor pharmacovigilance. I urge you all to speak to Ruth around that innovation. Okay, and then treatment of primary and secondary progressive MS. So who likes watching cycling? So you all know Dave Brailsford, I should say Sir Dale Brailsford. And so he brought to sport in this country the concept of marginal gains. And so when the British Cycling, the Olympic Committee saw how well Britain did in 1996, it came 12th with 2 bronze medals, they decided they needed some professional help. So they actually contacted Dave Brailsford, and he came in as a consultant for them in 1997. Okay, he was a consultant in 97, and you can see when in 2000 Great Britain had moved to 6th place, a few more medals, and then in 2004 they'd gone to 3rd place, and they kind of said eventually that actually he'd done a good enough job to get the big job. So he was given the British Cycling GB team to run. Okay, and his principles were, the whole principle came from the idea that if you broke down everything you think of that goes into riding a bike, and you improve it by 1%, you'll get a significant increase when you put them all together. And so he was actually officially in charge of the team from 2003, and you can see what he did in 2008. Okay, so there were 10 events, and Britain won 12 medals. Okay, 7 of them were gold medals. Isn't that remarkable? From somebody taking a new approach to training a cycling team. And I personally think we should do the same with MS. This is one of the reasons why we're having this meeting. If we break down everything we can think of that goes into improving MS outcomes and improving it by 1%, we get a significant increase when we put them all together. So I think we need to start thinking about how we manage MS in terms of this strategy, how we can break down everything we offer our patients and improve it. And I'm sure outcomes will be much, much improved. And this is why one of the work streams, well, 2 of the work streams that you're going to be participating in, are targeting the holistic management of multiple sclerosis. It's not only the things we think about when we manage MS, but it's also the other things around lifestyle wellness and all the comorbidities that need to be optimized. And focusing against aging, there's a whole new science about MS triggering premature aging mechanisms, which are part of the disease process. And I personally think unless we start thinking holistically, we're not going to maximize the outcomes for our patients. That's another objective of this meeting, is for people to think holistically about how they can improve their services, not just about providing a slick service in terms of disease-modifying treatments, but everything else that goes with it. And that includes one of the work streams, which is about access to treatments in terms of equality. So now moving on to shifting the treatment target, I think it's now unequivocal that if we diagnose and treat this condition early and effectively, I say early and effectively because that's what it's about. It's not the term aggressive. People think that this is about aggressive therapies. No, it's about early effective treatments. We actually change the outcomes. And the overwhelming data, both from phase 3 clinical trials, extension studies, and real-life data sets, are showing this over and over again. Those people who are diagnosed quickly, those people who are started on treatment quickly, those people who are escalated quickly, or those people who start on high-efficacy therapies earlier do better in terms of hard disability outcomes. And now we've got some new data that just emerged on survival. So access to these treatments early improves survival. And I challenge anybody to refute this model. It's pretty well established now. Early effective treatment is the best in terms of delivering outcomes for our patients. And so I'll go back to a personal story where my insights come from this. So this could have been my father. It's not him, it's a picture off the web. But my father had chronic renal failure. And he presented in his late 30s. I can't remember exactly how old he was because I was young when that happened. So he was in his 37, 38, and he presented with malignant hypertension. And he was found to be in chronic renal failure with a creatinine that was 600. And so at the time, there was nothing that could be done. He had to go into dialysis. And even when he presented, his kidneys were already shrunken and end stage and scarred. And the nephrologist said there was no point in even biopsying him. But the message about my father was when he was in his teens and early 20s, he used to get exercise-induced hematuria. And the family doctor ignored it. It wasn't like he didn't go. The GP ignored it. So he was never referred in. And the nephrologist said, it's pointless you coming to me now. I can't do anything about this. He said, you should have come to me when you were a teenager, and then we could have potentially diagnosed you and put in place treatment strategies to prevent. And I think the difference there is there was a Sentinel event. He had hematuria and was ignored. But in multiple sclerosis, we do get the opportunity to intervene. So our disease presents with a Sentinel event, or it presents with symptoms relatively early in the course of the disease that allows us as healthcare professionals working in this space to address the issue. And we need to take that seriously, very seriously, because managing MS is about preventing the damage. I'm sure we can spend our time dealing with the consequences of the damage, but it's not ideal. And so we need to take Sentinel meds. Now, if you're a diabetologist working on type 1 diabetes, there's little you can do, because most of the time people present at the end stage. They've lost the organ already. I say that, though, but there's just been a wonderful publication in the New England Journal of Medicine, okay, of preventing type 1 diabetes. So these are in siblings of people with the disease who are antibody positive, very high risk of getting the disease, and they were given an anti-CD3 and immune therapy, and it reduced their chances of developing type 1 diabetes. So even the type 1 diabetologists are moving their strategies earlier, and we should do the same. We should try and get in as early and as effectively as possible. And the people I admire the most are the rheumatologists. So when I was a medical student or a young trainee, we used to see this end-stage rheumatoid joint. We don't see this anymore. It's very unusual now to see end-stage RA joints, simply because the rheumatologists have taken this early effective treatment to the next level. They're the ones that pioneered treat to target. They're the ones that have pioneered diagnosing and treating and getting people's disease under control as soon as possible. And that's because, and that's even in the disease where they've got an option of replacing the joints. We don't have any option of replacing the brain and spinal cord. So if there's one group of clinicians we should emulate, it's the rheumatologists and how they manage rheumatoid arthritis and how they protect the joints. It's remarkable. So that's kind of underlying what's happening in this meeting is how do we optimize our services that everybody in this country who's got MS gets managed to the best, gets the best care they can get at the right time to protect their brains and spinal cords. And so that's why we want to actually go from being a passive to an active, and that's why we produced that policy document, Time really is Brain, because we now have evidence to suggest that delays in the diagnosis and management of MS appropriately leads to bad consequences for patients. And so we put forward this brain health, time matters in multiple sclerosis, but we had a real issue is what do we make the treatment target? What do we make the treatment target? Do we make the treatment target need no evident disease activity? And we know that's a moving target. So we actually came up with, okay, the aim is to encourage the widespread adoption of a therapeutic strategy to maximize the lifelong brain health of every person with MS. And I think that is my push today is to try and get you to think about your patients getting old. And what protects us from age-related cognitive impairment is the size of your brain, and we need to give people as much reserve so when they get old, they can age normally. And so the whole policy document was just about speeding up everything and making and trying to reduce delays, unnecessary delays in people getting their disease under control. So it's how do we get early referral and diagnosis, early treatment, monitoring, early escalation of therapy? How do we involve people with the disease in shared decision-making, collecting data and putting it back in to improve their outcomes, and then also focusing on economics because this is a document that was for the whole world, and we're living in a socialised healthcare system where we have access to these treatments. The NHS and NICE and NHS England have given us these therapies. But in other parts of the world, the limitation is cost. People just can't afford these treatments. So that's why an economic approach to try and reduce the costs of access to that. And we are working, actually we should hear in the next day or two, literally the next day or two, if the WHO has put MS on the essential medicines list. We've got 3 drugs going to go on that list, and why it's important is simply for politics. As soon as MS gets put onto the essential medicine list, it becomes a global disease of global significance, and which means politicians and healthcare systems all over the world won't be able to ignore it. So watch this space. I'll be the first to tweet about it, okay? Talking about tweeting, you can tweet on this meeting. There's a hashtag called MSVariance, hashtag MSVariance if you want to tweet about this meeting. So this is actually the timeline of the meeting. So the idea essentially started in May of last year. We had our first meeting in 2018, and then we got great feedback, but we got some really important criticisms, which we've addressed. So we've widened the participation. The meeting now has CME points, both from the Royal College of Physicians and your nursing body as well. Our steering committee now is much more inclusive. It's got a lot of diversity in it, so you'll see that. I hope that's addressed some of the criticisms we were given, which is important. And we set the agenda back in January of this year for this meeting. And the important thing was to have definite work streams that have deliverables at the end of this meeting. So that's what we're going to do at this end of this meeting. Each work stream is going to have to deliver something for people with MS within the next 12, 24, 36 months. And so our vision is that by July next year, we put out a national audit, be it a pilot audit. So we want as many centres in this room to participate. 2 years down the line, we would like patient partners, and we're partnering with Shift MS. I see Shift MS is over there. They're going to help us design a program to help people with the disease partner us in terms of delivering service. It's kind of like around self-management and self-monitoring and actually engaging with the MS services. And then 3 years down the line, we would like a no patient left behind scenario, Allistic management of MS, addressing the whole pathway, or all the pathways, not just the DMT pathway, which is how this meeting started off around DMTs, is about the holistic management of MS. And I also want to like to thank the Multiple Sclerosis Academy, because they're part of the Neurology Academy, and there's Sarah. Where's Jamie? For arranging this. And the reason why I put a little umbrella there, because this is an umbrella organization. We want the Multiple Sclerosis Academy to become like the unofficial British Society of healthcare professionals interested in MS. And the reason why we're using the MS Academy, because this is an inclusive organization. It doesn't matter what specialty or where you come from, you can be part of this initiative. It's not for neurologists, it's not for nurses, it's not for pharmacists, it's for anybody who's got an interest in managing people with multiple sclerosis. And there's 2 things that are overarching. We want to use this platform to share best practice, and that's why we got those posters outside. So please, we ask centres to put in posters around service developments or things they're proud of or put in place in their own services. So you should read those posters, and the idea is to share best practice. There's no point in reinventing a wheel. Okay, and then another thing is Gabby here? Gabby DeLuca? Not yet. So Gabby's going to, he made the point last year, there's no point in having these big ideas without having leadership. And he said, you need leadership skills. So Gabby's going to put in place a small, initially, leadership program to get people from this audience, not all of you, it's going to be quite a small number of people who go on a leadership program where you actually learn the necessary leadership skills to implement some of the change management issues that will emerge from this meeting. And the reason why Gabby's ideal, because he actually was one of the first young leaders that came out of the American Academy of Neurology Young Leadership Program. And he's going to bring, with Barbara, who ran it in the United States, they're going to bring that leadership program to the MS Academy. And so I think if some of you are interested, please put your names in the hat. We're looking for, it doesn't matter who you are, if you think you want to be a leader and you've got the necessary energy to do it, put your names forward. So we would like to get that off the ground as well to try and make this change happen. So the other work streams, there are 5 of them. So the first one's data. So David Rogg and Joella Matthews, they've been pulling together mainly Blue Tech data and NHS England data, and they're going to show you what data is available to you as prescribing centres or MS centres, and how you can use that data to see how well you're doing relative to other people. So that's very, very important. Work stream B is patients and partners. It's going to be run by Shift MS. Rob's going to be the Shift MS person who runs that. And that work stream is really to think about what needs to be in place for us to educate the people we look after with their disease and their families, to make them engage, be part of the services going forward. Work stream C is audit. This is actually probably the most important one. We would like everybody to agree on a common audit tool. There are lots of audits out there, but we need a set of core metrics. And Jeremy and Sue Thomas are going to produce that. And that's what's going to be for the next 12 months. We hope that everybody will participate in the first audit. It'll be a pilot audit. Obviously, it'll change. Then D is social determinants of health, and Helen is sitting over there, and myself are going to do it. This is basically to make sure we don't leave anybody behind. One of the things we have noticed is you all know that your social background and the level of education, your wealth determines outcomes. And it's what we have to put in place in terms of our service configuration to make sure we don't leave people behind that are vulnerable. MS is a very socially isolating condition, and we all got examples of patients who've fallen out of the system and get ignored, and we can't design a service without having systems in place to address the most vulnerable of our patients. So that will hopefully come out of work stream D. And then Agni's here. I haven't seen her yet. Not yet. So Agni's she's quite passionate about wellness and lifestyle, and part of that holistic management, her work stream is going to be creating a program or programs. I don't think there's one solution for each centre. Is how do we incorporate wellness and lifestyle programs into our MS management. I didn't choose these. These came out of the steering committee, these work streams. And if anybody's got any ideas for new work streams or new things that they would like to put forward, please ask questions. Ask questions. So these are the images. So the NHS, I think all of us are very passionate about the organisation we work for. We're very proud of the NHS. And it's very important that we stick to the principles. It's free at point of access, and it's equitable. We're not trying to reinvent wheels. We may want to redesign the wheel. So this is another important underlying principle of this meeting. It's bringing forward best practice. There's Gabby. Hi, Gabby. Innovation. Yes, everybody likes the word innovation, but it's about bringing new ideas. Obviously, partnerships. And clearly we need leadership skills as well. This is not going to happen unless somebody leads. And this is not leading at the top. This is leading, distributed networks of people, making sure things happen locally. And I'm glad, the fact that you're here tells me that some of you want to be the leaders. So hopefully the individuals who've come from your centres will go back and lead. Okay, and this little picture here, all these little things, it's about being inclusive. Okay, and about involving everybody in this process. So I also like to thank the sponsors, because we wouldn't be able to do this without sponsorship. Now, this is something that gets to me. Why should we have to prop up the NHS and things like this meeting, okay, by always having to get pharmaceutical sponsorship? But it's exceptionally difficult to do this without the pharmaceutical industry, and they have had no input into the agenda or the educational content of this meeting. They've just bought into the idea that we all want to do the same thing. So they want to work with us as partners in terms of proving outcomes. I'd just like to thank all 5 of the pharmaceutical companies for providing sponsorship and allowing us to have this meeting. And now I'll take questions. Thank you very much. So we've got a half an hour to discuss things. So that was another criticism last time. We had too much talking, not enough time. So we are now going to deliver on that. Less talking, more time. Who wants to ask questions or make a comment?
On the screen, you've got a question.
possibility of legal action from patients who have not met activity treated upon diagnosis and are claiming that this failure contributed to disability. It's a hot topic, that. I'm not a legal expert, so who wants to take a punt at that? Well, I can say we had a debate in London about a year ago. Joella was there, and there were a few people from this room, and it basically was a case scenario, and it wasn't actually a fictitious case scenario. It was based on a previous case. And that case actually didn't go anywhere. So this particular individual claimed that he was misdiagnosed or delayed diagnosis, was given an ineffective therapy for his level of disease activity, and he was a high-powered lawyer and lost his job in the city and felt his whole career had been destroyed by the MS team that looked after him. But he didn't win the case, okay, because at the time, maybe now he'd win the case, but back then he didn't win the case. So this actually does happen. And I didn't know this, but the barrister that came and spoke to us said to us that NICE is actually backed by an act of parliament and has legal status in terms of a NICE guidance. So when NICE put out a guidance, okay, a single technology appraisal, the NHS has to obey the guidance. And it's up to MS Services to put that in place. So if that person wasn't given access to those treatments, they do have a legal claim. And it hasn't really been tested in the MS space formally, but I think it's been tested in the oncology space. So does anybody got an opinion about this, Jerry? You don't have an opinion about this. So I do think that this will be an issue going forward, but that shouldn't be the way we practice. Why should we be in an environment that allows our patients to take legal action because they think the treatment they've been offered has been inadequate? Shamoon, you want to make a comment? No, I don't think Jackie's here. I think
she mentioned to me that in the DEVIC space there has been legal action against somebody who's been delayed, who got delayed treatment, and she sent a little email around, I think, saying that you should try and get DMTs going very quickly, because if they have a big relapse before they get a DMT, apparently there has been a legal case.
The thing about DEVICs, that there are no licensed or NICE approved treatments, so it's difficult. Okay, other questions? What funding, multiple in terms of patient on high efficacy TMT, should MS Services receive? I'm not sure I understand that question. David, do you understand that question?
Yeah, I asked it. So, thank you. So we talked about numbers of patients on treatment, numbers of patients in the service, but I think the monitoring and the burden that patients on high efficacy DMTs impart upon a service is a considerable other factor. So the purpose of my question was really the more high efficacy treatments we use, I think the more funding we will need to safely monitor and sequence them.
So I see Adrian Williams is in the audience. He's our chairman of the CRG, our clinical research group. Adrian, in terms of, I just want to ask you a question. So in NHS funding, what happens is these drugs are approved by NHS England. Okay. So they are specialist commissioning, and all the other services are local commissioning. But one of the things that's fallen into the cracks has been the monitoring. There is no extra resources for the monitoring. Is anybody addressing that funding gap in terms of the monitoring requirements, or do we just have to pick it up at the trust level?
Well, some of you must be part of the work stream in NHS England that's allowed to discuss whatever you want to discuss. So has it been brought up there?
Jeremy, has it been brought up there?
Yes.
Do you want to reaction to what your debate of mine in terms of monitoring? Do you want to? Sorry.
Yes, it was discussed as part of the group that were working on the optimal pathway for patients with MS at NHS England, and it was discussed, but no great solution was found because it is a really tricky one. Because as you say, all of the monitoring falls under a CCG tariff, but getting all of the CCGs to agree, that is the challenge that we face.
I think in our service we mainly pick it up at a trust level, and we do all the monitoring on ourselves. I don't know if the CCG pays for the extra MRIs and the extra blood monitoring we do. 3 more questions. What do you think NHS England will think of the concept of work you're proposing? So Jerry, Jerry, can you answer this question? Jerry Clough, he's a previous commissioner, so he may have an idea, because I don't know how to answer this question.
Well, it's complicated, right? So I think in general terms, NHS England, like all of you sat in this room, are looking for the triple aim improvement in healthcare. And, working within a different field, in a different constraints, and the politics and the budgets that underpin the national working NHS, that is what NHS England is desperately trying to do. And I interact with lots of fantastic people who are trying to do that every day. They have to manage an overarching budget for the system, which is dominated by the urgent and immediate that comes through the front door. And as I think I talked about at the event in November, you will always suffer from the fact, as lots of other parts of the NHS do, that the funding is dominated by the fact that A&Es are clogged up and people are there, and they're partly there because we haven't solved the longer term problems, and we end up in this spiral of treating what is coming through the front door. And as I said last time, the currency therefore becomes how many beds do we need to build in order to deal with the number of people coming through the door. I genuinely think, and I'll be talking about it a bit later, that if you can do more here to reverse that and to create any sense of optimism about what it is that you're trying to create, NHS England will gladly join in anything that looks more like a solution than a problem. There are a lot of people who present them ad infinitum with problems that require more funding and because whatever part of the NHS is growing. But the more that you can do in this room to help with that, I think the better. I don't think there's an easy solution, but I wouldn't get it locked into NHS England don't care about different parts of the NHS. It's a very difficult and political job that they're involved in.
Yes, I used to I was a centre lead in my institute for 8 years. And people never came to me unless they had problems, basically. And you're smiling. But the people I used to love interacting with, the people who came to me with the problem but the solution at the same time. So I think that, as a previous leader of a research group, I think that's the kind of people, those are the kind of people you like to deal with, people who identify the problems but also the solution. It's not just coming with problems. So I think this meeting or these series of meetings we're having, we're responding to an issue. None of us enjoys our jobs anymore. Well, I'm not saying that for everybody, but we finished doing our clinics very frustrated because we're not delivering the right service. And I think it's because we are plugged into a Victorian way of delivering healthcare, and we need to change that. It needs a fundamental change in the way we deliver healthcare or MS services. And I think that'll bring the mojo back in terms of what we're doing. We just most MS services are just putting out fires. That's everybody shaking their head. I can just see everybody shaking their head. We need to work differently. Adrian.
I think you've been handed an opportunity. So
Yep.
I think if you guys work together on the work stream that I know David's on, NHS England have asked for you to redesign the service. And I think you should make sure you all push in the same direction, because I think that's what it's asking for. I fully accept the A&E thing, but that's not SpecCom. So you've got an opportunity to go through SpecCom to actually go through a different route where you're not competing against A&E quite so obviously anyway.
Yeah. So there's a real positive message. There's this point up top. There's an emergency use license for highly effective reversible DMT whilst awaiting MDT, etc. possibility. So Klaus didn't come to the meeting. I think Klaus Schmirer, who's a colleague of mine, came up with this concept of actually using one of our disease-modifying treatments, natalizumab, to get people's disease under control before we actually finish anything in terms of their workup and pathway. And but the point about it is that we need data for that, because that's not going to get NICE approved. That's not going to get commissioners to pay for it unless it's data-driven. So yes, it's a lovely idea, but I think we need to have data to do that. And that data, the quality of the data is going to have to be, in my opinion, high-quality data to do that. To show that very, very early emergency use of disease-modifying therapies to protect the brain and spinal cord needs to have concrete, hard outcomes to show that it's worth using. I have no doubt from personal anecdotes, there are a few patients I look after that tragically did very badly from catastrophic MS, in the first few weeks to months. I think we've all got a few of those patients in our practices. And this strategy, if you can select those patients and start them on a treatment very, very early, I'm talking about in days of them presenting, we may be able to prevent some of those catastrophic outcomes. But we need data for that one. Is there a personal budget available to MS patients for use within the NHS? I have no idea. Who can answer this question? Sue, can you answer this question?
Yes, I have known people.
Okay, this is not...
Yes, I have known people that have had personal budgets that they've used to manage their...
But that's usually social services and that, isn't it?
It is, yes, but you can apply for one. And
but this is not about MS services, though.
it's not about MS services, it's about an individual having their own personal budget.
Okay.
And I guess Shift MS might be able to kind of shed some light on that, because probably some of the people that are involved there have got personal budgets. Or some of the nurses may well have patients with personal budgets.
Anybody make a comment about that? So there are personal budgets for social services, but I don't know about MS services. Social services. Bernie? What?
There are some for healthy living in certain London boroughs. So, for example, in Islington, if you are diagnosed with MS, you can have a personal budget that you can use to go to the gym, to do your Pilates, do yoga, so wellness type personal budgets, but it's by individual CCGs.
So that's coming out of NHS money?
Yes, yeah.
Okay.
So but again, there's a geography piece around it.
So anybody else got that available to them? Would send to you from Agne?
We have healthy lifestyle clinics running at Torbay Hospital. Again, it comes from the trust money, so there is a budget for chronic diseases.
So that's something we should maybe aim for. Can we bring to the attention on NHS England the DMT monitoring tools that has been developed? We need more administrative support, but CCGs are not prepared to do this. So that's a piece of work that needs to be done. So under the MS Academy umbrella, they have brought together a tool looking at all the disease-modifying therapy, pharmacovigilance, and that's something that could be done as part of this meeting in terms of improving MS services, is how do we address that issue. So yes, it can be done. I'm not sure who's going to... I think there are people working on it. Who's working on this? Sarah, are you working on it? Bringing that to the attention of the NHS England. Okay. So it is being done. How can you differentiate between good and bad variation in the provision of MS service in NHS? Should we only focus on the bad ones? No, I don't think so. That's the whole purpose of monitoring, is that you get I heard this, a standard deviation, you get a range, and so there will be people that are at the top end, and there'll be people at the bottom end. And that's one of the things about these kind of initiatives. You very rarely get rid of the variation. You just raise the bar so everybody goes above it, and there'll always be variation. And it's not only about focusing on the bad. That's why we got those posters out there, and that's why we want people to share best practice, so we can also share in the good variation. Yes. So at the same time, when we're talking about that, we would like you to go around and browse the posters, and you each got a little card on your table, in your pack, which is voting for the best poster. So we would like to give an award at the end of to the best poster. And we are going to choose one or two of the posters, maybe three, to come up on stage and present what they've done, so everybody can hear about how the motivation behind that particular project and how it changed their practice. So please do that voting. Just coming back to that, so I don't know if you know, in the United States, they do a national audit on epilepsy surgery departments. And there's a proportion of patients that have epilepsy surgery for intractable epilepsy. And they begin to realize that that actual number relative to the total population they're looking after is actually a quality metric. And so if too few patients are having epilepsy surgery, it means that they're not doing a good enough service. In other words, there are people who need to have surgery and not having it. And I suspect the same thing will happen amongst us in MS, is that there will be a proportion of patients, I don't know what that proportion is, that need to be on very high efficacy or high efficacy therapies. If they're not, then we're not looking after that population of patients. Now, some people will disagree with me on that, but I think that potentially could emerge as one of the metrics, is that if you're going to look after people with MS, you'll have to have a certain number of them on high efficacy drugs. It's just the nature of the disease. And if you've got very few, because some of those blue tech centres have got extremely small numbers, if none at all, on second tier or high efficacy therapies. And so we've got to ask the question, why? Are they referring all those patients to one of the central centres? That explains it. If that doesn't explain it, then there are people in that particular centre that have been disadvantaged by the practice in that centre. So that's an example of variation that may be unwarranted. What is the right amount of variance in DMT prescribing, and who should decide this? I have no idea. Who wants to give that a bash? Helen, can I ask Helen Ford to answer this question? Give it a go, Helen. Is there a microphone here for Helen?
Yeah, I mean, there's some concern about what the blue tech data is telling us. So I think if you rely a lot on blue tech data to look at variance, I think you need to understand what the underlying centres are doing. So there are some real funny bits where a centre may only be prescribing one drug, but that is the way the services are set up locally. So I think to get more understanding about the variance, you need to really understand how our centres are working. And some of that variance actually may be positive because some patients are being seen more locally and not being pulled into a centre and having to travel far for specific drugs. I think it's hard to say, to be prescriptive, especially when we've got the NHS England algorithm, which allows multiple choices at different parts of the MS pathway. So you could only really define it if you had a very prescribed decision-making at each stage of the MS pathway. And at the moment, using the algorithm, there's such a lot of variation in what can be used at a certain point. And the other thing to remember, we've done a lot of work about this. This isn't just about the prescriber. So this isn't just about the neurologist. It's about the person with MS and their decision-making and the things that are important to them in their life. And that has an influence on what decisions they might make at different points of their MS journey.
Yeah. Maybe we should get an MS nurse. Sarah, you want to have a comment about this? Because you're having to implement decision-making. Sarah White here in the middle.
Karen's just said I don't need a microphone. She's very rude. I agree with what Helen said, but I think from the patient point of view, patients don't always make the choice that perhaps we think would be the choice they should be making, because everyone's individuals and everyone has a different risk that they want to take, whether they want to go in hard and choose a drug with more risks attached to it, or to have a drug that's been around for a lot longer with less risk. So I think we, as clinicians, can only give them the advice. I think one of the problems, as nurses that we're all facing is actually having the time to go through each drug and explain all the differences between them so that they can then make an informed choice. But I think it's right, we deliver all the drugs at our centre, but there are some local hospitals that deliver part of the drugs, some of the injectables and the orals, and just come up to George's if they need the infusion. So that would, on Blue Tech data, make it look like one centre's not giving any injectables, whereas actually they're just coming from a different centre.
Okay, next question here is there more we can do to adopt innovation in digital health, digital therapeutics, etc., AI? What does IoT stand for? Internet of Things. Okay. To better support MS patients. So we've got Bernie, she's one of the NHS Innovation Fellows. Bernie, you want to give a go to this? Bernie, would you like to give it? There's a microphone coming.
Yeah, I think, obviously, I think there is. Part of it is about how do we communicate the barriers, describe the barriers, understand the enablers in the system, and understanding our patient groups. I think we're making a lot of assumptions about use of apps and the confidence of people with MS to use some digital applications. We need to check those assumptions again, especially with our more progressive patient groups. But definitely I think there's a real room for improvement. What we need to do is have a culture where we share and learn and collaborate together to get these things diffused across the NHS from out of one centre into others. I don't know if Rachel wants to add.
Rachel, do you want to make a comment on that?
Well, we use quite a lot of technology up in the Western Isles, so and the patients have embraced it quite well. We have an organisation called Empower that will actually go in and help patients use technology in their own homes so they feel more comfortable with it. So we're very fortunate to have that.
Well, I think that's the reason why you're forced to do it, because you're stuck out on the Western Isles. So getting to the Western Isles can be very problematic at the best of times, and it's so it's what's driving the adoption is the geography and the need for it.
To give an equitable service across the islands, really, it's been a need, really, yeah.
So yes, this is the answer, but it needs to be done carefully, and and that may come up in Jeremy's work stream in terms of working differently. Is there more we can do? That's the last question. So I think, should we move on to the next section then? Which of the areas identified on your perfect storm slide do you feel have the biggest impact on variance, and which would you prioritize to address? Yeah, so I personally think it's got to be the holistic management of MS. It's we've got this. Forget about. I mean, I'm sure we can do more. I'm sure we can do more within our current environment if we reconfigure things. If I have to give you it's about changing epidemiology of MS and the emergence of therapies for progressive MS. That's the thing we have to really get our head around. Is the increasing incidence. And the treatments that are emerging for the progressive phase of the disease. We have no idea the real impact that's going to have on us over the next 10, 15, 20 years. That's going to be enormous. So we have to think differently. We have to develop a new system to deal with those three things happening. I think David's there's a poster up from, what do you call it? You call it the apocalypse. Apocalypse now. Not quite now. But they've modelled in Manchester some of these issues based on trends over the last few years, and the trend is like this, and what you need in terms of manpower and time to deal with that. And it's the fact that they use the term apocalypse explains to us why it's the most important thing on that list to address. Okay, so that was a good warmer. People are getting involved. Please use the Slido so we can get more questions. I think the discussion is very useful, and hopefully it'll get people thinking, and as you think, ask questions. We can use the discussion session later on Even if it's not relevant to that particular talk, put it up there and we can keep it in reserve. Okay, so there's the next question. Do people agree lifelong brain health is a target for health, should be a target for health services? Yes, no, don't know. This is a really loaded question. Anybody can vote. Looks like it's unanimous, eh? So I achieved one aim, is getting people to buy into the holistic management and targeting brain health, which is good. It makes us having to think very broadly. So now we're moving on to the next talk, and this is going to be access to MS services. There's going to be a double act. Sue Thomas from Commissioning Excellence. She's Chief Executive Officer Commissioning Excellence, Wilmington Healthcare. And Martin Fisher from, he's the Director of Fisher Associates, are going to give us their worldview of how we're going to improve access to MS services.